All right. Hello, everybody, and welcome. We're going to go ahead and get started. Welcome to the National Physician Suicide Awareness Conference and webinar. We are we have a few goals and objectives that we wanted to share with you from this panel today. Our first is to increase awareness about physician suicide, which is why we chose today to do this panel. We also are going to be discussing burnout, the prevalence of physician suicide, and inciting and mitigating factors, as well as providing resources to help prevent physician suicide and support physician wellness. And so my name is Dr. Melissa Parsons. I will be one of your moderators today, along with Dr. Sarah Williams. And these are our panelists.
So our panelists include experts in physician suicide and well-being from across the country. Dr. Peter Yellowlees from UC Davis, Dr. Betsy Fiddleson from Columbia, and from Stanford, Drs. Andra Blomkans and Jose Maldonado. Our first speaker is Dr. Jose Maldonado. He's the medical director of psychosomatic medicine and chief of psychiatric emergency services and transplant psychiatry at Stanford. He's certified in adult psychiatry, psychosomatic medicine, forensic psychiatry, addiction medicine, and forensic medicine. He's the chair of the Stanford School of Medicine Faculty Senate and president of the American Delirium Society. He's also very experienced in helping departments, including ours, navigate through suicide-related tragedy. So welcome, Dr. Maldonado.
Thank you. And thank you for having us and particularly having this group of panelists for this very important topic. With regard to this presentation, I have no conflict to reveal. And a few things about physician suicide that are important to discuss. First of all, doctor or physician suicide has been spoken for a long period of time. It's unfortunate that we have to talk about it because in essence, it means two things. A, has not gotten better, and unfortunately, it's getting worse. If you look at the statistics that I put here, every day, 1+ physicians will die by suicide. And there are multiple reasons why that might be the case. As you see, there's a fairly high burnout rate that others are going to address. There are questions about the work balance or work-life balance, given all the needs to document and other activities that particularly those of us in academia have to do, but everybody who is day-to-day dealing with patients. And there's a fairly high incidence of clinical depression among physicians. It is important to realize that the number one way by which physicians complete suicide is still firearms, which is exactly the same methodology used by the general population, followed by poisoning, which unfortunately we have access to, blunt trauma, particularly accidents or so-called accidents, motor vehicle accidents, and then asphyxia. There's a number of factors that have been associated with the high incidence of suicide among physicians. Some things are historical, like a previous suicidal attempt, but others besides burnout include discipline, the fear of losing your license, lawsuits, etc. So there's a number of factors that are included, all of which are listed here. And for the brevity of case, I'm not going to go through many of them. But one thing that we want to keep and pay attention when our colleagues might be the victims of suicide is not just performance issues that will be associated with depression, but the presence of anxiety and hopelessness, which are really important. Now oops, I went a bit too fast. There's a number of reasons why, unfortunately, my transition didn't work out there. But unfortunately, what you see here is that these are the risk factors. To the right will be the access to mental health care. But in between, there's a number of factors that prevent physicians from accessing care. Fears of confidentiality, the fact that we ourselves sometimes have this hero syndrome and we consider ourselves the last one to consider something like that. Concerns about reputation and license, as well as hospital privileges, are among the main factors for which physicians do not access care, including fear and, of course, denial. And, it is unfortunate to realize that even though physicians in general, and most of the studies were initially carried in male physicians, when you look at the statistics among physicians in general, you see that there's a significant greater rate of female physician suicide compared to the general population. Still more male physicians die by suicide, but compared to the general population, the rate of female doctors or female physicians dying by suicide is still staggering. One of the main things to consider is that doctors are particularly bad at taking care of themselves. Doctors by far tend to access care, both physical as well as mental health care, in a fairly high rate. But when it comes to mental health, the main concern is something that we need to change, which is when you go to assess for privilege, whether it's at your institution or in the state, there are many places where they still ask if you have had any concerns about mental health, which is something that we need to remove. So my bottom line here is that physician suicide, along with burnout, is a crisis in medicine these days. It's fair to say that we physicians are the canaries in the coal mine when it comes to mental health issues in the healthcare industry. The rate of suicide is significantly greater, even that of active military members. And I think it's really going to be up to us, up to physicians, which is why I think that you guys are doing a great job by putting a webinar like this, because if we don't change the culture, nobody's going to change it. One of the first things that we need to change is this requirement for medical boards and hospital privileges to have to declare whether you have a mental illness or not, or whether you have received mental health or not, because that either stops people from telling the truth or it stops people from accessing the care that they need. It is also really important to implement critical incident debriefing programs in every institution where suicide might occur, whether that is one of our colleagues or one of our patients. So recognizing that medicine is a human endeavor rather than an assembly line is going to be one of the only ways that we're going to be able to all succeed. And I just have a list of resources for you that is going to be available. My email is on top if anybody ever wants to contact us. Thank you.
Thank you, Dr. Maldonado. Our next speaker is Dr. Peter Yellolis, who is the Chief Wellness Officer at UC Davis and Professor of Psychiatry. He's also the Vice Chair for Faculty Development in the Department of Psychiatry and Behavioral Sciences. He's conducted research in the areas of psychiatry and physician health, including how new technologies can be used to promote high-quality care and improve physician well-being. Welcome, Dr. Yellolis. Dr. Yellolis, your mute is on. Dr. Yellolis, your mute is on. There you go.
Okay, so thank you very much indeed, Sarah and Melissa, for inviting me, and I apologize for that mix up with the mute. I also want to give a quick shout out to Catherine Tyler, who I saw in the audience there, and Catherine has been a colleague of mine working on physician wellbeing at UC Davis for quite a long time now, and has done a fantastic job from the emergency medicine perspective in particular. So what I'm going to be talking about is more of the solutions to suicide in physicians. And I have two disclosures, but they're both very relevant. And I've taken information from these two books that I've written for part of this talk. The book on physician suicide actually looks at this whole area from a clinical perspective. and is really targeted towards people who are treating physicians or to physicians who are unwell and potentially suicidal. Whereas the physician well-being one is very much more about the prevention side of things. Both of these Dr. Maldonado mentioned, and I think both are very important. So these are complementary books, but coming from very different perspectives. Now, one of the things that's really interesting about physicians is that there's been a number of studies, and this is just one, that have found that physicians, when they actually enter medical school, are more healthy than equivalent graduate students. So here, less burnout, less depression in matriculating medical students compared with age-similar college graduates, mainly doing PhD programs. And so we start out really well. And I think that's a very important point. It's very important not to blame physicians for burnout or for the ultimate, obviously, potential of suicide. And we actually work in a system that is very dysfunctional, as most people on this call will know, and which is very difficult to work in. And it's there that we really have to make the big changes. Now, we know that approximately 400 physician suicide each year, and that females do this more commonly than males, proportionately, compared to the general population. We know that a lot of physicians experience burnout, and that our overall drug of choice is alcohol. So these sort of background statistics are worrying. The reality is we really don't know how many physicians actually do suicide each year, and the 400 quoted here actually comes from a study that was done in about 2000. Now, there are 5 major physician health issues that are clearly different from the general public. The first is burnout, what Dr. Maldonado talked about. The second is what we call disruptive behavior, which is physicians essentially behaving badly and becoming difficult and unpopular, especially with their colleagues. The third is aging, and how do we ensure that physicians who are aging and who want to continue working clinically are fit to do so. And the fourth are obviously the psychiatric disorders, and finally substance use disorders. And all of these different types of issues can be part of a pathway towards eventual suicide. Now, so how do we change this? I think there are 4 areas we have to look at very broadly. The first is we have to improve access to care. As Dr. Maldonado correctly said, physicians often don't like getting care, and there are many barriers in our way. So providing many different pathways to care is really important, not just the traditional self-referral or referral via a primary care physician, but at least a number of other approaches that I'll mention in a minute, and giving and making it easier for physicians to seek care with less stigma involved. Very interestingly, the patients that I see who are physicians really enjoy seeing me online. And actually, that's been one of the nice things about COVID, the increasing acceptance of being treated by video. And certainly this is an ideal format to use to help physicians. Secondly, we have to change the culture of medicine. That's not an easy thing to do, but we've got to look at being prepared to help each other more, to work more in teams, to be more supportive, to set up peer responder programs, critical incident debriefing, and things like that. We need to improve the efficiency of the way we work. We all blame the EMR to a certain extent about our burnout, but there are many other areas where we're incredibly inefficient, and we need to look at our workflows and try and work in a way that has us working at the top of our licenses, as are all of the people who are working around us. And finally, and I think least importantly, we need to reinforce our own resilience. And I say that because actually as physicians, we're very resilient in the first place. We've actually got good resilience, but we can always learn to do that better and to learn a few more techniques and approaches. So just moving on to 2 very specific solution-related areas. The first is the development of an anonymous mental health screening program that at UC Davis we've been running for nearly 7 years now. UCSD has been running this for about 9 years, and many other academic medical centers are taking up this program, which actually comes from the American Foundation for Suicide Prevention. This allows physicians at any time to go in and self-assess using a 36-item set of questions. They can essentially assess whether they are high, low, or medium risk for suicide, and whether they potentially meet criteria for needing to have a referral for mental health problems. And we've offered this to all of our physicians now, as I say, for about 7 years. During that time, whilst the physicians all go in anonymously, we obviously then can go back and forth with them with a clinical psychologist on the other end of the software. And if they eventually decide they would like to get some help and get a referral, they can break their anonymity, and we will then arrange their referral. But there's no reason for them to break their anonymity if they don't wish to. Ultimately, we've actually referred 97 of our physicians into care in the last 6.5 years. The majority have gone to either a psychiatrist or a psychologist, and 62 of those people have been at the highest level of suicidality in our tier 1. Half have been residents, half have been faculty. So that's actually an extraordinary number of people to refer into care. And what we're trying to do with this program is to pick up people when they're at a relatively early stage, typically with anxiety, depression, or substance use, and to get them treated before they become impaired, before they become suicidal. And my view is that this type of self-assessment program is something that all physicians should have offered to them. And the second thing that we've done is really focused on education of all of our physicians and physicians from other places. And jointly with UC Irvine, UC Davis has set up a fellowship program in physician well-being. The first year we had 17 physicians who took this program. This second year we have 28. And we're essentially teaching a very detailed 6-month curriculum on physician well-being, which was actually the reason that I originally wrote those 2 books that I featured earlier on. The intention of this is to turn a whole cohort of physicians into trainers on physician well-being, so that they can take all the resources that we have and use them in their own health systems to train their colleagues and to actually help make the cultural changes that we need to make within healthcare. So we're trying to essentially develop a whole series of experts in physician health as rapidly as we can. Now, I think those are very obvious techniques. This is my final technique that I'm going to mention to all of you. Look after yourselves, relax, and enjoy life. Thank you very much.
Thank you so much, Dr. Yellowlees. I will go ahead and introduce our next speaker. So we are going to have Dr. Andra Baumken. She is the professor of emergency medicine and chair of the Department of Emergency Medicine at Stanford University. She is currently president of the Society for Academic Emergency Medicine's Foundation, as well as past president of SAM, an active member of our AWEM community, and chair of the SAM Wellness Committee. And so a lot of SAM titles, and she is going to join us today to speak on this matter. See her slides coming up. Welcome, Andra.
Hello there. Thank you so much for having me. I really appreciate being here. In terms of disclosures, I will say that I am not an expert in this field. I had the sort of horror and privilege of having a faculty member die by suicide roughly a year ago. And my goal in this is to relay that experience and also provide for you some of the steps to move forward and try to help a group heal after that. And I hope none of you have to experience that. However, I learned a lot through that and made a lot of mistakes, but I'm hoping to give you my best in terms of what I thought worked or didn't. So I was cherishing sleep one night in August in 2019, much as we all do, when I was awakened by a phone call. And it was my clinical director, and I've changed the names for the sake of anonymity, and this was my clinical director of the adult emergency department, who said, Andra, it's Samantha, how are you? And I thought that was a really weird question for 12:30 in the morning. I'm like, what do you mean? And she said, well, I have some bad news. And I thought, okay. And in my mind, I was thinking, okay, there's some dispute with another service about an admission, maybe a bad patient outcome, which would be terrible. But what she said next, I had no capacity or understanding of how to even process the information. And what she told me was that one of our faculty members died by suicide, and she was giving me that information, sort of like I guess a hot potato in a way, and I just want to describe what's next. So my first question to her was, well, what about Tracy? And in this rendition, remember, names have changed. Tracy was his wife, and coincidentally, Tracy was also a faculty member in our group. And I wanted to know how or where was she? And Samantha replied, we're not sure. The police found some of her belongings at the scene, but they did not find a body. And Terry, who is another faculty member of our group, is the one who found him. And so now we have 3 faculty members involved: the person who died by suicide, his wife, and then the individual who found him. And she knew, and Samantha at this point knew nothing more. And I mean, what do you say at this point, right? You say, okay, thank you, and call me if you hear anything else. And Samantha was the administrator on call at the time and had no other information. So at this point, I felt like it was in my lap. And that was okay, other than I had just lost my cat of 21 years and I hadn't slept very well for 2 nights. And I sat there and thought to myself, okay, what's next? What am I supposed to do? I know I'm supposed to do a lot, and I'm not sure what I'm supposed to do. I consider myself a scholar of few things, but one thing, a scholar of leadership books, and nothing had I ever read or listened to prepared me for what to do next. And I feel like all of us as leaders in academic emergency medicine need to consider what we're going to do, because this will happen to us someday. Sadly, it will happen. And I think knowing what to do next is very important. So who do I call? What do I do? I ask all of you to put yourself in the same situation and try to think of what you would do next. What happens today? It was already 1 o'clock in the morning by that point. And what happens the rest of that day? What happens tomorrow? And then, oh my gosh, as a department, can we get through this? I mean, I had never imagined anything so catastrophic for the culture of a department than to have a faculty member die by suicide. So like a comet hitting the earth in sort of an apocalyptic experience, I at first talked to the police, and even the notion of how do you talk to the police? You dial 911 and say who you are. And eventually I got dispatched to those police. And at that point, they suspected that maybe his wife, one of our faculty members, was also potentially dead, and that they were still trying to find her whereabouts. And they promised to call me if they got any other additional information. I called the dean, who happened to be on vacation on the East Coast, and told him, and he was very receptive to my phone call and very compassionate. And I just felt like I needed to tell him, and that's my immediate kind of command support. And I also called the vice dean, but her message went to voicemail, which is also very acceptable at 2:00 in the morning. I called my departmental leadership or my executive team. Then by this time it's the next morning, and I'm trying to figure out a construct of communication to faculty, staff, and trainees. Many people have heard of this already. However, we did track down the wife, who was out of town, and she was not comfortable at that point with disclosing that it was a suicide. And that is a key part of all of this, is that loved ones often do not want to disclose that it is a suicide. And at that moment, I obviously want to respect her wishes. And at this point, I'm in the office. So I had one gathering in the office, and this is back when we used to go to the office, with all the staff and faculty who were there, and described that something terrible has happened and that there was a lot we needed to do, and I needed their help. And I'm not exactly sure what those demands might be. And we moved forward. In that time period, I contacted our Chief Wellness Officer, Tate Shanafelt, and also Jose Maldonado, who just spoke, and quite frankly disclosed my vulnerability and said, what am I supposed to do here? And I'm not sure who suggested it, but somehow we ended up doing a very informal pizza and beer outing at one of the courtyards within Stanford. And along with that, we brought our spiritual care services and also several psychiatrists from Jose's department. And the goal there was not to have a memorial service. The goal at that point was to acknowledge a tragedy within our department and have people talk. And I'll say it once again, that having people talk, I think, is talk about it, talk about how they feel about it, recognize that something happened, is so incredibly pivotal towards healing. Questions that crossed my mind and I didn't know at the time were, what resources are available to faculty? I had no idea. And oftentimes in academic institutions, the residents or the faculty might be hired by different entities, and they have different benefits, and what's available, what's not available. I had a lot of help with Jose and Tate and everything to try to figure that out, but it was my responsibility to know what the resources were available. And legally, like, what could I disclose? What could I not disclose? I wanted to do the best possible thing for the department and the institution and the family involved, but I wasn't sure of my legal rights. Fortunately, after a day, the wife was okay with disclosing that it was a suicide, and she and I together crafted a message to everyone else. And then we were able to actually undergo some significant discussions about what to do. I want to share a couple slides, just very few, from our society's survey of wellness and academic emergency medicine, and just a couple things to think about. One, that with 95% confidence interval, those who are significantly burned out are considering a change of career outside of clinical medicine. And I think sometimes we think a lot of people do that, but the significance of going through that much training to suddenly decide that maybe you don't want to be part of it is a real red flag. I feel like in emergency medicine, we've done a great job recruiting people, because we tell them about all the good things. It's shift work, it's exciting, you never get bored. You get to do all these things, you get to do procedures, you get to be a cognitive person and all these things, but we don't tell them, or we don't highlight, that we work holidays and nights and weekends. And sometimes what we do is incredibly frustrating or socially challenging or otherwise. And I'm not sure we necessarily tell the people who are going into emergency medicine the complete truth. And so if people were, what emergency medicine was what they expected, they were professionally fulfilled, but not so if they weren't. Lastly, and this is germane to our present situation, do people work when they're sick? And emergency physicians in general will always work when they're sick. That's not going to be socially acceptable anymore, but people who work when they're sick are more likely to be burned out. So in closing, I want to tell all of you, this will happen to you. One thing I faced when I was going through this was so many of my colleagues across the country and here saying, this happened X number of years ago with X or Y. And so I feel like it's up to all of us to be prepared. The best thing we did was talk about it and talk about it some more and talk about it in another forum and continue talking about it. And I really think that helped the department I don't want to say get over it, because we'll never get over it, but at least we were able to get through it. It's a departmental responsibility for all of us to look out for one another and to intervene if we feel that something is wrong. It's, you know, with the notion of Black Lives Matter and everything, it's our job to be an upstander, not just a bystander to people feeling poorly. And I think everybody is owed the responsibility of intervening if we feel like that's necessary. We'll never forget what happened here at Stanford. I think we learned a lot since that time. I'm very grateful to people like Jose and Tate for helping us through this portion of this to this point. And lastly, I think it's so important to express gratitude for everything we do, and the notion that physicians, it's not work-life balance. In some ways, being a physician is part of your life, and it's incredibly important. And you can't get away from it. So thank you for having me. I'm sorry if that was particularly morose, but I just wanted to relay my experience honestly. Thank you.
Thank you so much, Dr. Blomkamp. Our next speaker will be Dr. Betsy Fiedelson. She is the director of the Women's Program in the Department of Psychiatry. I am going to share her slides as I introduce her. Her area of expertise includes the evaluation and treatment of psychiatric disorders across the female life cycle. And she has experience also in crisis management, ECT assessment, public psychiatry, and resident and medical student education. We are so glad to have her joining us this evening on this panel.
Thank you so much, Melissa, and to all my fellow presenters. I'm not sure if I'm appearing here in the speaker view, but anyway, it's an honor to be part of this panel today, and I have to say I don't have particular expertise in physician suicide, but I am a participant in our collective trauma that's ongoing right now, in the multiple collective traumas, and I've had the honor of bearing witness to what my colleagues have been going through in New York at Columbia and elsewhere. So I'm going to share some of my perspective as someone who works with a lot of trauma at Baseline and has had the honor of being a liaison working with my colleagues in the Department of Emergency Medicine in the last 6 months. Okay, next slide. I don't have disclosures but that are relevant, but I am grateful as always to programmatic and salary support from these foundations. Next slide. So I want to start by honoring and acknowledging the life and the loss of a colleague, Dr. Lorna Breen, who I'm sure many of you know and knew. And Lorna died by suicide on April 26th of this year. Her family, in the aftermath of her death, have been extremely active and have really taken on such an admirable advocacy role. And in fact, if you don't know already, you should know that there is a a bicameral bipartisan act, which in this day and age I think is quite unusual, that is sponsored by Senator Tim Kaine and others, called the Lorna Breen Healthcare Provider Protection Act, which aims to establish grants in evidence-informed strategies to reduce and prevent suicide and burnout, identify and disseminate evidence-based best practices for reducing and preventing suicide and burnout among healthcare professionals, establishes a national evidence-based education campaign, establishes grants for employee education, peer support, and mental health and behavioral treatment for healthcare providers, and establishes a comprehensive study on healthcare professional mental and behavioral health and burnout, including the impact of COVID. If you want to know more about Lorna or this foundation that her family has set up in her honor, I put the website there as well. Next slide. So I'm going to lead with my take-home points, and I'll try to be brief. And I'm focusing here on the impact of COVID and how it has highlighted some of the stressors that we have all been talking about in the last half hour. So firstly, the ongoing COVID pandemic puts extraordinary strain on healthcare systems and individual clinicians, but it's an acute on chronic condition and exacerbates and highlights underlying systemic problems that put physicians at risk of burnout and suicide. The second point I want to make sure that you walk away with is that mental health interventions are incredibly important and necessary, but insufficient. We need to address the conditions that create risk and that put physicians at risk of burnout and suicide. In the pandemic, this includes the need for resources, knowledge, and support for safety and efficacy. And well-being or mental health support is important, but stigma and the culture of medicine are still major barriers. But also, I want to emphasize that the COVID pandemic also presents opportunities for intervention and changing the culture. I'll talk a little bit about the COPE Columbia program that our department, Columbia, has put together in collaboration with many other departments, and end on a note of resiliency. Next slide. So one important thing quickly is to just recognize emotional distress and even psychiatric disorders do not equal impairment. Just having a psychiatric diagnosis or having emotional distress, even high rates of emotional distress, does not equal an impaired physician. In fact, there are many, many physicians I treat who I would and trust my life, my family's life, my children's life with. So this is part of the stigma that I think really needs to be overcome. Next slide. This study, this is very hard to read, I apologize, but there was a study that Ari Schechter and some of my colleagues in medicine put out earlier this year, where they surveyed a number of healthcare providers across the New York Presbyterian healthcare system starting in April. I think the first email they sent out was April 9th. So really right at the peak of when COVID was, cases were peaking in New York City. And they asked questions, many health questions, but included questions on psychological well-being. And as you can see here, the rates of qualifying for acute stress disorder, depressive symptoms on the PHQ-2 screener, and anxiety symptoms were quite high across the board, but did vary in this relatively small sample. It was about 1,000 people who answered by specialty and training. Interestingly, and this is going to be impossible to read on the slides, but I encourage you to take a look at the paper. The things that the most people identified as sources of stress was overwhelmingly the sense of lack of control and uncertainty, as well as their fears of contracting COVID, of infecting their household, their family members, the isolation from their family, lack of training, lack of PPE, and a sense that they might not know what to do for their patients. Next slide. A much more recent brief systematic review from a group in Norway looked at the many studies that have come out in the last 6 months about the psychological impact of COVID on mental health, on healthcare providers, as well as on interventions. And what they found was that, not surprisingly, rates of anxiety, depression, distress, and sleep problems are elevated in healthcare providers who are affected by the COVID pandemic. The biggest risk factors were junior status, higher exposure, longer quarantine time, having an infected family member, lack of practical support, stigma, and younger age. As in the last study, distress and anxiety were elevated by all the risk factors: exposure, risk of contracting the illness, etc., and a sense of it being inadequately trained and lack of resources. Protective factors included clear communication from their institution and with colleagues, access to adequate PPE, adequate rest, practical and psychological support, social support, and a personal sense of control. However, most of the interventions that they looked at focused on individual psychological factors, not necessarily organizational factors. And there was a quote from the study that said, many staff mentioned that they did not need a psychologist, but needed more rest without interruption and enough protective supplies. And only a small minority of providers identified a willingness to access professional mental health assistance, even in the midst of the pandemic. Next slide. Yeah. So our department at Columbia, as our, psychiatry, like many other places, went very quickly, 90% remote, with some notable exceptions, but really felt like many of us, like we really wanted to be helpful to our colleagues. And my vice chair, Lou Baptista, as well as colleagues Laurel Mayer and Claude Mellons, put together the Cope Columbia program, which is staffed by a core group in our faculty, as well as a number of voluntary faculty and other volunteers. And this group focuses on support, coping, mitigation of emotional fatigue, and resilience building. The purpose is to promote well-being with quick links to mental health treatment when needed. It's available to all Columbia Medical Center providers and staff. It's free of charge, peer-driven, totally confidential. No notes are taken. Next slide. And the interventions we offer, the core of it has been or initially was peer support groups. So 30 to 60-minute virtual groups, co-led by a psychiatrist MD and a psychologist, that were specific to different departments and divisions across the medical center, really providing a space to discuss challenges, enhance resilience, and adaptive coping skills, and foster a sense of team support. We also offered one-on-one peer support sessions, which were 20 to 40 minutes with a similar purpose, but in the one-to-one virtual format. It was sort of a walk-in type thing where you could call the day of and get scheduled to see one of the clinicians virtually, and they were connected in real time. A number of town halls and webinars focusing on different aspects of mental well-being, emotional well-being, and mental health, including trauma, and training in different specific skills, as well as developing a website. And the website is here. We can send it out later. It's a little hard to read on this slide, with resources for managing stress, fear, and anxiety, and trauma and loss. And I can say that this has been the most meaningful thing I have done from the in the last six months. I'm grateful to be a part of it with wonderful colleagues, and I'm so appreciative of being able to sort of bear collective witness with my colleagues across the medical center. And I'll just go very quickly. I'm sorry, I know we're running out of time. Next slide. So just, sorry, go ahead. Okay. So there's a number of themes I'll go very quickly through. Some of the fears and anxiety, sense of guilt, helplessness, difficulty connecting, feeling overloaded, transitioning in and out, anger and numbness. And the next slide. But there's also a lot of themes that we heard in our groups and in individual sessions about feeling a stronger connection to peers across departments, being deliberate about self-care, communicating the positive to each other, gratitude, inspiration, and appreciation, bringing humanism when they're not able to save a life, to bring humanism into the room, effective teamwork, a shared sense of mission, values-based action, as well as a permission to be vulnerable with colleagues when this is usually not considered acceptable. Next slide. So I'll end on our resilience tree, and I'll just make the point that resilience is not a stable trait. It is a state that can be built and developed and rebuilt and redeveloped over time. Thank you.
Thank you so much, Dr. Fidelson.
Thank you, Betsy. We're going to go to Q&A now. And so I ask all of our panelists to consider some of these questions and answer accordingly. One that was texted to me kind of privately, not in the group, was are physicians who commit suicide always obviously anxious or depressed? I was wondering if anyone can comment on that.
I mean, I'm happy to comment on that. What we know about people who actually kill themselves is that the great majority certainly do have a depressive illness or some other psychiatric disorder, but about half of the people who actually successfully kill themselves, in them it's an impulsive act, and it's something that happens quickly and suddenly, and is perhaps even not predictable, 15 or 20 minutes before. But they happen to have access to some means, like a gun, and they use it impulsively. So I think it's a combination of things.
I wanted to say something very similar to Peter's comment. One of the things that we know about suicide in general, and there's no reason to believe that physicians are any different, is that suicide tends to be a problem of opportunity. So it happens when it happens. I think that we, particularly all of us who work in the emergency department, sort of get cynical and burn out by borderline patients who come in time after time with suicidal ideation. And we are used to ask about suicide plans, etc. But like Peter said, most people don't chronically appear suicide, nor are they thinking about suicide at all times. And then they reach their breaking point. And then the question is the opportunity, which is why when we look at the numbers of successful suicide, firearms are so high on the list, because it's completely irreversible.
So I received a follow-up question on what symptoms or signs we may look for in our colleagues and those that we're working with that may clue us into this in advance, and if there are any.
You go first, Jose.
Well, I was going to say that usually is a change in the behavioral pattern that we need to pay attention to. I mean, there have been several times when I'm walking around the medical center and I bump into one of our colleagues and I put them aside and I said, what the hell is happening with this? And then they pull me into a room and break down and start crying. So just has to do with the fact that we work with them all the time. You know your colleagues. If you see something that is a significant change in their behavioral pattern, chances are that they're not going to come out and tell you, but most suicidal patients, if you ask, they will tell. So giving them the opportunity to express and offer help in a timely basis. And sometimes you might not know exactly what to do, but then be with them and help them reach out to the right person. And before I forget, I want to say something about Andra's presentation. She was really tried by fire. I mean, what Andra had to go through when our colleague took his own life, I don't remember how long you've been there, but not that long. And then suddenly I remember getting the call from Andra and trying to, brainstorm with her what to do. And then I saw the evolution, not only in Andra, but in the department over a very short period of time. And that was amazing. So for somebody who didn't know at the beginning what to do, you grew a lot and you took the department through a phenomenal transformation for the best.
Thank you.
If I can just quickly jump in and just add a couple of things to what Jose was saying. I mean, I think one of the issues here is when you see someone behaving differently or presenting differently, you need to have a system that allows that person to come forward and talk to someone, as Jose was describing. And one of the approaches that we're using
I think you froze.
I think so too.
He'll come back.
Yeah.
He'll come back. Although something he's mentioning here is related to a comment and also a pre-submitted question. And that is around, Kat Ogle made a comment in the chat about mental health services still being a part of credentialing packets that we are asked to complete for our onboarding physicians. And the question that relates to is that there's a concern that disclosing mental health conditions could lead to consequences like higher rates with disability insurance, or even concern when applying for jobs and credentialing. And how do we begin to change these practices? Because it directly relates to the amazing support services that are being put into place and people's sense of if they are actually allowed to take advantage of them.
Right. So they are. You can go to your state medical board, and it will tell you. Unfortunately, sometimes hospitals don't follow the state rules. In fact, when our colleague died by suicide at Stanford, and I had to go through this process, I realized that even though the state of California does not ask, Stanford Hospital did. And now we have changed that. So I think one of the things that we all can do as leader in the medical community is make sure that we approach our inboarding systems in your medical center and make sure that there are no questions. The problem is the lifetime question, right? When the package says, have you ever received any mental health care? It will really make people either lie or not want to answer. It is true that if any of us is impaired physically or mentally and is current and is not taken care of, we might have to disclose that. But I think that we all agree, and Betsy made the comment that is actually true. Many people who might have died by suicide at one point probably were completely competent and able to perform their duties, and therefore fool everybody, including their loved ones, as in the case that Andra was presenting just minutes before that. So is having the opportunity to do that. So if physicians are asked or demanded that they disclose whenever in their lifetime they had seek mental health, they probably will not seek that help, so they don't have to lie, or then they have to lie. Either which way makes you feel bad. So there are about 14 states in the nation that still ask questions about a lifetime history of mental illness or treatment or hospitalizations, and that is completely inappropriate. And I think that is important for physicians in those states to continue to request for the medical boards to delete those questions out of the package. And by the way, your institutions, as we learned at Stanford. And I'm happy, Sarah, to give you the map that has all the states and which ones are congruent and which ones are not with the recommendations of the American Suicide Society.
It was actually very interesting when California changed their rules about 18 months ago. I was involved in lobbying to the medical board at the actual meeting where they made the decision to change the rules and to move to essentially only 2 questions that related to, are you currently impaired?
Right.
And I think that's a fair question. because it means that actually people are encouraged to get treatment so that they're not currently impaired, and obviously then to take out any questions about the past.
Yeah, I'd add that most of the professional organizations, including the American Psychiatric Association and I believe the AMA, have physicians advocating against asking that lifetime question. And if you are part of any professional organizations, I would encourage you to encourage them to take a position opposing that.
And I'd just like to add that the individual in our faculty, I would have never predicted. Like he didn't look depressed. In anything, he looked the opposite. And I think what we all can do is sort of normalize seeking help or seeking care or seeking conversation. Because I don't think we can just look at people and try to figure it out. I think it's sometimes, as Jose and Dr. Yellowlees said, it's a opportunity thing, and we have to allow people to feel open to help themselves, even though we want to help them when we can. That might not always be possible. So we need to make sure that everybody feels very open and willing to seek help if they need it.
If I can just jump in again, because I know that I froze before and I'm not sure exactly how much was heard, but I think one way of doing that is to have an effective peer responder program whereby you train people in psychological first aid. You then, in our case, I'm doing this with Katrin Tyler and a number of other people. We give people badge buddies, and we're just actually handing those out at the present time, so that if you're a trained physician or a trained nurse as a peer responder, you actually carry it around with your badge, and it says peer responder on your badge. And what that says to anyone, such as the physician that Andra was talking about, is that you're a safe person to approach. You're someone who actually understands, who's been through a training process, who's going to listen primarily, and if necessary, will refer you for care. Because it's very threatening and very difficult for physicians to actually make that first approach.
One of the things that did happen in the aftermath of Dr. Breen's death was that we actually worked with the Department of Emergency Medicine to do what we called an opt-out one-to-one session with one of our Cope Columbia volunteers, so that everyone in the Department of Emergency Medicine was scheduled for a session. They could opt out. It was purely voluntary and anonymous who would come or not. But ultimately, based on the numbers, about 70% of the department did talk to touch base with one of their psychologists or psychiatrists through that program. And a number were linked to care through that as well. So I think there are ways, especially in the aftermath of a tragedy, to be proactive about offering anonymous support as well.
The last thing that I wanted to add to that is that physicians, and I think that emergency department physicians or emergency medicine physicians are probably liable to experience, to some extent, maybe more than other physicians, is this second victim syndrome, given all the tragedies and the traumas that come through the emergency room. And for us physicians to recognize that we're vulnerable to that vicarious traumatization, having debriefing built in within negative outcomes in the emergency room is probably a way to address the issue before it becomes a real problem later on. I think Andra had done a great job at that when it has happened in the emergency room, not only when we lost this physician, but subsequently. And I think that is a great model for us to put into practice going forward, because it's a way to normalizing seeking help, just by bringing the help to people when we all recognize that it was a traumatic event.
We've been given the go-ahead that we can continue recording longer if there's an interest, but I also want to be respectful of people's time. The panelists available to stay for maybe 5 to 10 more minutes, or?
Yeah. I am.
Yep.
Okay. Well, deepest thanks. So let's plan on maybe 6:10 p.m. as the end. So if you have a burning question, please put it in the chat now.
As we're waiting for burning questions, I wanted to also, I was thinking Christine Moutier actually came and spoke with our, at our hospital today, and she made a point that I think is really helpful, is to, how to make it clear that you're a safe person for someone to self-disclose to discuss openly, perhaps, and to be willing to be vulnerable and discuss openly some of your vulnerabilities, the feelings. If you're seeing a therapist, there was a thread on Twitter not long ago about doctors saying, I take medications, I see a therapist, it's great, so really using that to change the culture and also identify yourself as a safe person to talk to. And another point, that if a colleague tells you that they're talks to you, you don't have to disclose to, there's no like required reporting for a colleague who's telling you that they're struggling emotionally. I think that's the emotional distress is not impairment, right? Like just telling a colleague doesn't put your job at risk.
So I want to add that in one of the small groups we had, and I think Jose was in the room actually, and we had a facilitator, and we had several faculty groups over that time. And it was a wonderful, wonderful faculty member who said, hey, I don't know if you guys know, but we have this feature where we can go talk to somebody for 6 times about an issue. And I did that once. And it must have worked because I can't remember the issue. But the notion of that she disclosed that she sought help,
Yep.
That it helped, and that it's okay to seek help was so powerful. That obviously I still remember it to this day, but it was just great to have somebody who said, yeah, I sought help and I don't even remember why. So it must have worked, and it was very, very nice.
So Dr. Blumkin, one of the questions that we have had is, how did your department heal over the past year after the event at your institution?
That's tough. I'm not sure how we can measure that. I will say a year after his death, I had it happened to coincide with one of our departmental happy hours with COVID. And I announced that we were going to talk about it and have a moment of silence. And also talk about some of I contacted his wife or widow at that point to say, what would you feel comfortable that we talk about? And she said, well, if people have them share good things about his life. And so there were over a dozen people who each shared some feature of what they remember about him in a good way. And then we went on with the rest of the sort of happy hour. So I think we've made progress. I don't know. I really don't know, because it still haunts our department's past in a way that will never go away. And I can't even look at the screen because I'm afraid I'm going to like burst out into tears. But I think we've made progress. I think some people have healed, and I think we've come closer as a department. And hopefully we feel more comfortable reaching out to each other.
Thank you for sharing.
Thank you, Andrea. Question to the panel around, can the panel speak specifically to the support of women in medicine, specifically as regards mental health?
Betsy, do you want to take that one?
Yeah, sure. I mean, I certainly, I think it's so striking that the rates of suicide in women physicians is so high compared to the rates of suicide in women in the general population in particular. And I'm not the expert in that. I mean, I think you spoke to some of those pressures. But I think that we do need to do a better job supporting, acknowledging the ways in which women may be at more risk in our field in medicine. Both because if you look, if you look across academic medical centers, and there's still a lot of gender disparities, let alone the racial and ethnic disparities, but gender disparities in endowed chairs, in associate professors, in professorships, in achievement in academic medicine, and the ways in which achievement is measured, and the ways in which women are told they need to behave or not behave in order to succeed, are certainly things that need to be looked at carefully, as well as the rates of sexual harassment and other gender-based disparities that occur still within medicine, the field of medicine. But I defer to my colleagues on, who are with more expertise in physician suicide to really address some of the differences in the rates that we see in suicide.
There was a paper by or a study by McMurray and colleagues in 2000 that specifically looked at the issue of mental illness and suicide in female physicians. And the main factors raised by the respondents were a feeling that they have less control than the male counterparts, the fact that on average they make about $20,000 less per year, and they reported, female physicians reported a 1.6 times greater odds of burnout. That, along with all the other things that women amazingly deal with, like childbearing and spouses, etc. They're all factors that lead to problems with not only burnout, but also higher risk of suicide. In a separate study by Gold, among 2,000 female physicians, 50%, and this was an amazing number, 50% of them reported that they felt that they met criteria for some form of mental illness, from an adjustment disorder to either anxiety or a depressive disorder, 20% of which were writing their own prescriptions because they either feel that they didn't have an opportunity, the time, or because they didn't want to acknowledge that there might be something wrong with them. So obviously the system is not built in to access or provide the access that they need. And if I remember correctly, about 22% of them, the ones who sought mental health, 22% of them pay out of pocket because they didn't want anybody to know that they had gone to a mental health provider. So even though we spend our life caring for people, as I said initially, we don't do such a good job taking care of ourselves. And I think that the system is not built to make it easier for us.
And if I can just add to that, I mean, to me, the real core issue here is sort of diversity, equity, and inclusion. Whilst we've all become very aware of that in recent times with the racial inequality that's been going on, the reality is women are in the same situation, and within medicine generally. And to me, you know, every well-being program does need to have a very strong focus, and every department should have a very strong focus on these DEI type issues. And I think that is, in some respects, the long-term, one of the big long-term cultural changes we have to make within the profession.
Okay, we still are getting questions in the chat box, but we agreed to stop at 6:10. So it would be great if we could figure out a way to get additional resources out to the group. We can brainstorm on that a little bit. But I wanted to really thank every panelist, as well as AWIM and SAM for this presentation. I think an important take-home point is that we've come a long way. I've been practicing medicine now for about 25 years, and when I started, you didn't talk about it. You just didn't talk about it. And now we've gotten to the point that only 14 states ask about it. So I think we've made huge progress. So just be there for everybody, be there for each other, and have a great evening.
Thank you very much.
Thank you.
Thank you very much.
Thank you.